Hi everyone, my name is Melanie Grant, and this is CNM Glass. Today we're focusing with our class 2030 on our third part of E&M coding 99201 through 99499. Today, our big key points, we're going to talk a little bit about putting it together, kind of a refresher on some of the key factors that we've looked at already, or key components, the role of time-based billing, and then some of those unique E&Ms that you'll notice aren't exactly based off of the key components that we've been focusing on the last 2 weeks. We're going to wrap this up with a second video going into some of these unique E&Ms and billing both of them together, or an E&M visit with another service that may be done within the office. Okay, so let's get started. We're going to look first at putting it all together. So by now, you've already reviewed the type of E&M service, determined that by looking at the type of service, does it require things like new or established, inpatient, initial or subsequent or discharge days, and do the key components apply, or is there something else that it's based off of? Make sure as you look through these that while you realize the key components will always be the same for each service as it lists them, you may have different requirements for what makes a certain level. When you say level 1, 2, 3, and 4, that may be different if it's new or outpatient or inpatient or established. And all of those factors are important in making sure you select the right code for your service based off of where you're at. Also, pay attention to coding guidelines and make sure that even though we may have a lot of details, we do need to support medical necessity. What this means is a provider cannot simply come in for a common cold and bill a level 5 without supporting cause. They may do a complete exam and a comprehensive history on the patient, but the question that Medicare would ask them and any other insurancing agency is, was this medically necessary? And if it's determined that it wasn't necessary, then they could end up losing hundreds of thousands of dollars and being accused of abuse of the Medicare system if they're a Medicare provider. More importantly, that can hurt our patients. So we always want to support what is it that is supported and performed, and make sure that we look at either 2 of those 3 or 3 of those 3. Now on your medical scorecards, you have the final sheet, which I'm going to pull up here now. Let me see here. The final page of the medical scorecards actually has kind of a bringing it together cheat sheet. Most coders, or at least I personally, don't like that particular cheat sheet because it can be a little confusing up front, and sometimes it's easier just to go through the book to determine where we're at. However, I want to make sure that we have familiarity with this and that you all understand what you're looking at when you see these, because it can come in handy for those of you that like scorecards like this. So let's do a quick review while my computer pulls it up over here. To start, we know that our 3 key components are history, exam, and medical decision making. Okay. Within the history, we have certain key components of HPI, review of systems, and PFISH, or past family and social histories. Under exam, we have either the 95 or the 97 guidelines, and those have specific elements or areas. And under medical decision making, you have, let's see. And under medical decision making, you have 3 categories, which are diagnoses, data, and risk. Risk being split up into 3 that you pick the highest from. Okay, and for medical decision making, you do 2 of the 3 categories that are the highest level of medical decision making, that are both of the same level, to determine the overall medical decision making. For the exam, you look at specific elements or body areas and count how many apply. And for history, you have to have all areas within the same category. And don't forget, of course, your chief complaint, which is required. Okay, So remember last week how I said you want to take it each step at a time. One step at a time is also key here. And keep that in mind because that's going to help you. Okay? So when we look at these, we take our history, we take our exam, and we take our medical decision making, and of course this closed on me. There we go. And we come into our scorecards, we're going to put it all together on that final and fourth page. Now that final and fourth page is broken into a few categories. And so when you look at those, remember the abbreviations. Remember things like PF for problem focused, EPF for expanded problem focused, D for detailed, and C for complete or comprehensive. And sometimes other ones like high or minimal may apply. Okay, so I have my sheet up here. And the first piece of your scorecard, if you notice to the top of it, 5 level of service says new office, outpatient, and emergency room. And then to the right of that, it doesn't say, but it says established. So you have new office to the left for new patients in the office 99201 through 99205. Then you have your ER, and then on the right you have your established office patients, which are 99211 through 99215. So you see at the bottom of that it'll say the level of service and the code. And this is what I'm talking about here, the one that looks like this. I know it's probably not easy to see on the video, but if you haven't by now already pulled up your scorecards, you should be on there and looking at the final page, which is number 5, level of service, page 4. Now, for the first part, you see how it says history exam, complexity of medical decision. And then it has PF, ER, PF, PF, ER, PF, SF, straightforward, ER, SF. All of these correlate to the previous pages for straightforward, problem focus, expanded problem focus, detailed, and so on. And your goal is to look and see in this area for new office, outpatient, or ER, it requires 3 components within the shaded areas. So that means it's 3 of 3 key components. If you correspond that in your CPT book to look and say, what does it require for a new office outpatient patient, you'll find that under 99201 through 99205. And we can go there in our books now. And you'll see here, Office and Other Outpatient Services, always read your guidelines because it's going to tell you a little bit of detail about where to find inpatient care and other services such as ER observation. And then it has new patient, 99201. Office or other outpatient visit for evaluation and management of a new patient, which requires 3 key components: a problem-focused history, a problem-focused exam, straightforward medical decision-making. It also goes into time-based billing, where it talks a little bit about counseling and coordination of care and how much time that is, and we'll talk about that in a minute. And then you go to the next level, and it's a level 2 or 99202, expanded problem focus, straightforward medical decision making. So what they've done here on this number 5 of your scorecards is they've put that all together so that you can say, okay, I had a problem-focused history, an expanded problem-focused exam, and a straightforward, no, let's say a detailed medical decision-making, okay? And so we have that, and then we say, okay, remember that whatever is higher here also includes the lower, although that's only 1 here, and whatever's higher here includes the lower. So if I'm a new patient here and I'm trying to determine what's my overall level of service, I'm going to say, okay, I have 1 key component under detailed, an expanded problem focused here, and a problem focused here. And for a new patient with a problem focused history, the highest I can go is 99201. Okay? So for here, 99201. Even though my decision making may be higher in this example for detailed, I can't go higher because I require all 3 levels to be the same. So 3 out of 3 key components, The only one that matches is here, here, and here. However, if this is an established patient, which is going to be on the next page, 99211 through a 99215, I'll see that a 211 requires a problem-focused history and exam, yes, and straightforward medical decision-making, so it can be here. It also can go up to a 99213 for an expanded problem-focused exam with a medical decision-making of low or higher history. And let's put L here for low. Okay. A 99214 requires either a detailed history and exam and or with a medical decision-making of moderate. So we'll put M here for moderate. So just kind of throwing that together here, I had a moderate, not detailed level of medical decision-making, but I had an expanded problem-focused exam. Here and here are 2 out of 3 key components. And so if I'm looking at this and I'm saying how many do I have at the highest level for an established patient, then I can go to an expanded problem focus for 99213. So if I compare that, a level 1 new patient visit versus a level 3 established patient. And it's always important to remember that. Okay, so let's look at our next thing. So that's all for just kind of an overview. If it doesn't make sense or if you still have questions, there are going to be 5 charts. The first one is the chart that was used for the E&M activity over the last several weeks. And then 4 additional charts that I've provided, which I will also have a breakdown with the scorecards separate for you later this week. So take your time to go through those, see if you meet those. We will be talking about that in our discussion board post this week as well. So if it still doesn't make sense, try a couple practice ones. It always helps after you've practiced a couple. And of course, feel free to post in the virtual cafe or send me any questions, and we can code some of these together this week during coding clinic or our coding review with Miss Melanie if you'd like. For our next topic this week and some new stuff this week, we want to talk about time-based billing. Okay? Time-based billing is an opportunity with medical codes for evaluation and management specifically, permitted that they are not already a time-based code. You can go in and you can look at the total amount of time that's typically spent. So looking at those same codes, I had 99201 and 99213 a minute ago. Let's look at those. Under 99201, counseling and coordinating care with other physicians or other qualified healthcare professionals if agencies are provided consistent with the nature of the problems and the patient and or family's needs. Usually presenting problems are self-limited and minor. Typically 10 minutes are spent face-to-face with the patient and or family. So time, if it's greater than 50% spent of the total visit on counseling and or coordination of care, can be your only component and override those visits. So let's look at that for a minute. Let's say that we have a patient who spent 30 minutes with the provider, but their key components were problem-focused history, an expanded problem-focused exam, and because they were a complicated case, they had a moderate medical decision-making. These are those same ones that we looked at a minute ago. Now, in this example, the key components are either going to be for a new patient, 99201, or an established patient, 99213. But for a 30-minute visit, if the provider documents and documentation must be exact, okay? If they document that the patient has spent greater than 50% of the time, and they have to specify what that is to support it. So if it's a 30-minute visit, not talking about the scheduled time, we're talking about actual visit time, face-to-face with the patient. This is part of what must be exact. If at least 16 minutes or more of that was documented that they spent time counseling with the patient or coordinating their care, then we bill off of time instead of these components. Let me give you an example. A patient comes in with, let's say, a asthma attack. Okay? And let's say that this is 2 days later. So an asthma attack 2 days after. We stay really focused in our history just on the asthma because it's a serious concern that the provider wants to go over. The exam is fairly limited because they're only focusing on respiratory issues. And the medical decision making, of course, is going to be a little bit higher because they're dealing with things that are, while possibly resolved, a chronic condition that is exacerbation, even mild, will be a medical decision making with a higher risk, a new diagnosis, that's automatically going to be a moderate medical decision making. So we know that we've broken this out. The patient came in, they had 2 days ago, they had an asthma attack, they used their inhaler, they were better. They came in today because they need a new doctor to prescribe a new inhaler, and they need to go over and make sure that there's no additional concerns. Our provider spent a minimal amount of time with them in terms of service, but a lot more time in terms of counseling and maybe even coordinating care. So in this case, coordination of care applies if the provider is spending time with the patient face-to-face, calling other doctors, going over plans for them, such as, okay, I'm going to have you go and see this x-ray and do these labs, and then you're going to come back here, we're going to discuss. Those are all kind of interchanged with counseling, but it does have to be face-to-face. So counseling by itself doesn't specify what it needs to be done or how it needs to be done, just that it's face-to-face. This patient may be really concerned about the asthma attacks and be talking to the provider who feels that we have a pretty good grasp on it but wants to ease their mind. And especially if it's a patient who's a child and the parents in the room, this can be a longer visit. Now let's presume this was a new patient. If I spend 30 minutes and I counseled 16 or more minutes of a 30-minute visit, spent face-to-face, counseling on, this would be a perfect example of a note. You can do the math and see that the time is greater than 50% of the overall visit. They should be giving you exact numbers, not how long was scheduled. So if they went over, they used the number that was over, whatever the actual face-to-face time was, okay? 16 minutes of 30 minutes visit spent face-to-face counseling on asthma concerns. We discussed X, Y, and Z. It should continue from there and say what was discussed or why that was important, because we still have to support medical necessity for that time. At that point, we're going to say, okay, even though we have these key components, our time is a total of 30 minutes, and we bill time off of the total time, not the counseling time. So we have a 30-minute. If this was a new patient, I would go in here and I would see a 99203 is going to equal to 30 minutes. And instead of a 201, I'm going to bill a 203. If I have an established patient, remember that was a 213 previously, that's only 15 minutes face-to-face. So if I look at 30 minutes, the closest I have that meets that is 25 for a 99214. And this is a good question. What do I do? Because the 99215 says 40 minutes. In this case, you would go with the lower of the two times that meets. So because 25 minutes is within 30, but 40 is more than what we spent, we cannot go higher than the 214 for 25 minutes. This still, however, does support a higher level of service. Oh, I'm sorry, not a 5. And make sure when you're sending your bills in, you don't mix the 4s and the 5s, because the insurance company doesn't like that when it's not supported. Okay, so if I'm billing off of time, just to recap, I have a 99201 off of a 30-minute visit that's properly documented can become a 203 off of time. And that's what you should be billing because it's what's accurate. If I have a 99213, an established level 3 office visit, and based off of proper documented time, it comes up to a 99214. Even though that's only 25 minutes and the total time is 30, I can't bill higher than what was actually performed. So I bill the highest that's available off of what was performed. All of this time should be your face-to-face time, not the nurse time, not the provider's time away from the patient, only what's face-to-face. So that comes together and bills our total visit for time or key components. I'm going to pause the video here and start our second one, where we're going to talk about unique E&Ms and billing for multiple E&Ms on the same day. Thanks for your time for this video. We'll see you in just a moment.